Hello, everyone, and welcome to Neurocracy. Today we're joined by Dr. Mignot, a Craig Reynolds Professor of Sleep Medicine at Stanford University and the Director of the Stanford Center for Narcolepsy. He's best known for discovering that narcolepsy is caused by loss of the brain cells that produce orexin, a key chemical that helps keep us awake. His groundbreaking work has changed how scientists understand the biology of sleep, and he continues to study how genetics, the immune system, and even artificial intelligence can help reveal what happens when we sleep. Dr. Mignot, thank you so much for joining me today.
A pleasure.
So, my first question for you is what first got you interested in studying sleep, and how did that lead to your groundbreaking work in narcolepsy?
I have to admit that it was mostly chance uh,
Okay.
because I did my medical school in France. And at the time, it was many years ago, you had to do your military service. So you had to spend a year in the army. And when you were a medical doctor, you could delay going to the army until you finish your medical school. But then you had to do 1 year abroad. And I convinced the French authority to study a drug that was used for narcolepsy at Stanford that was called modafinil or
Okay.
Provigil, which is still being used. And
Yeah.
it was a French drug, and I convinced the French government that by studying it at Stanford, maybe the drug will be sold, to the US, and that will help, and it happened because it's still a drug that's very used, actually
Yeah.
in the US to treat patients with narcolepsy and sleepiness. It's called modafinil or Provigil.
Okay. That's very interesting. So, the next question is kind of about like famous work in narcolepsy. So, how did you first discover that link between orexin and narcolepsy? And could you explain why that is such a major breakthrough?
Mhm. So, I mean, initially when I came, I started to work on narcolepsy, and again, this drug that was supposed to be used for narcolepsy. And they had a colony of narcoleptic dog that had been funded by my predecessor, Dr. Dement, who passed away a few years ago,
Okay.
was my boss at the time. And, you know, I got interested in how the drugs that we use for treating narcoleptic patients are working. But then very quickly, I realized that it was not going to give me the breakthrough I waited for. It was just like, okay, maybe I could improve a little bit the current treatment by changing a little bit the drugs and trying them in the narcoleptic dog to see if it helps them better than other
Okay.
drugs.
Yeah.
But then quickly I realized, this is not going to be transformative. So these dogs had a genetic defect. If you bred them, they all develop narcolepsy.
Okay.
So I basically kind of tried to find narcoleptic dog all over the country that had that genetic mutation,
Yeah.
try to isolate the genetic mutation by studying the families of Dobermans and Labradors that existed in the country.
Wow.
And it took me 10 years, but at the end,
Wow.
I found the smallest piece of the chromosomes that was common to all these dogs with narcolepsy, these Dobermans. And it turned out to be a receptor for this chemical called orexin.
Yeah.
So suddenly, orexin, which was thought to be involved in appetite, became like, oh my God, this is a cause of narcolepsy. It's probably something that helps you to stay awake. And then when this receptor is mutated in dogs, you develop narcolepsy.
Yeah.
And then quickly, I realized that in humans, it's a slightly different cause. It's not a mutation
Yeah.
because, narcolepsy doesn't run in families like in dogs.
Okay.
It runs partially in family, but it's not like very genetic. It's not 100% genetic. It's more like a risk. And we discovered that it's not the receptors that mutated, but the chemicals that's missing in the body of patients with narcolepsy. We just measure that we did a CSF tap, like
Okay. Yeah.
global
Yeah.
transfer, and then we could measure the level of the orexin chemical in the CSF, cerebrospinal fluid, and we
Yeah.
discovered that in all patients with narcolepsy, it was completely absent.
Oh. Yeah.
Normal in normal people like you and me,
Right.
it was like 300 picogram per milliliter. So that was the cause of human narcolepsy.
Yeah. So, for people who don't know much about narcolepsy, could you describe what it feels like and kind of what's going on and maybe a molecular level or more like a chemical level, I guess?
I mean, the symptoms are fairly straightforward.
Yeah.
Patients with narcolepsy are tired all the time and they fall asleep very quickly.
Yeah.
So they wake up in the morning. Usually they're okay, I mean, usually. And then after 1 or 2 hours, they feel tired again. And then they have to nap again. And then after a nap, they usually feel better. And then they
Okay.
have to wait for a few hours and they have to nap. And, they have to nap all the time. And they have these very strong sleep attacks,
Yeah.
like I'm sure it has happened to you, like you
Yeah.
can't really keep your
Right.
eyes open.
Yeah.
Very, very strong. And then but they feel better after a nap. And
Okay.
then dream a lot. So they have very vivid dreams. Sometimes the
I
dreams,
believe, is it like hypnagogic hallucinations?
exactly.
Okay. Yeah.
Dreams are sometimes they believe it has really happened. So
Oh,
I have
wow.
patients that believe that someone enters their room in the middle of the night and broke
Yeah.
the windows and stole stuff. And they wake up in the morning, they're pretty certain it happened because it was so vivid.
Yeah.
Sometimes they're also paralyzed because during REM sleep, during dreaming,
Yeah.
you, you are paralyzed.
Is
So
that cataplexy?
no, that's called sleep paralysis.
Oh, okay, okay, okay.
So you wake up and you can't move. It can be very scary. It
Yeah. Yeah,
happens
yeah.
to normal people actually sometime. You
Yeah,
wake up
that
in the
has
dream.
happened. It's like a weird state when I'm like out of a REM like dream when I'm like forcefully waking up. I can't move for like a second, if that makes
Ex-
sense. Yeah.
Exactly. So that's very common in narcolepsy. But
Okay.
what's really the most weird symptom, and this one is unique to narcolepsy. If you have that, you have narcolepsy. It's very odd, is when patients get emotionally excited, they're happy about something, usually joking or laughing around something funny, a joke. If they make a joke with a friend,
Yeah.
suddenly they lose their muscle tone. So same way as they are paralyzed during REM sleep, and they crumble to the floor, or they just cannot
Yeah.
lift their head or they cannot talk. And it's almost always when they are laughing or joking about something. It's
Uh,
very odd. We have no idea why.
yeah.
It's interesting. It has to be funny. It has to be, it's not like ha ha ha. It's like something that you personally find funny. I mean, it's almost impossible for a narcoleptic to give the punchline of a joke. If you
Oh, because okay, I see.
then you feel paralyzed. And
Yeah.
of course, that's not very nice. And then in patients with narcolepsy, they gain a lot of weight. Also, when they start the disease, especially in childhood, they can gain, you know, 60 pounds sometime in six
Wow.
months. It can be really dramatic. The younger it starts, the worse it is.
Okay.
So that's the symptoms of narcolepsy, and you have it for the rest of your life. And the
Yeah.
cause you ask, but that's very simple. This
Right.
orexin chemical is missing. So
Yeah.
the cells that produce these orexin chemicals, so there's about 70,000 out of the
Yeah.
billions of neurons that you have in the brain,
Yeah.
gone. And that's why you have narcolepsy. So it's not complicated.
Yeah. So is there any potential for treatments or like therapies, I guess? Could you elaborate a little bit on that?
Yeah, so the very good news is that for years, we were treating the symptoms of narcolepsy only with symptomatic drugs.
Okay.
So, like drugs that treat the symptoms, but not the cause, like when you take
Right.
aspirin for fever or
Yeah.
something like that. So, we were giving antidepressant because they suppress dreaming and REM sleep, so they kind of improve the cataplexy, the bad dreams. Or we were giving stimulants like amphetamines, like
Yeah.
ADHD drugs to stay awake,
Right.
or some very, very strong sedative that help you to sleep better at night and feel more rested in the morning. But these really don't treat the cause, which is the lack of this orexin. But recently, in the last 2 or 3 years, there's drug companies that have created drugs that can replace the orexin. So
Oh.
orexin agonist.
Yeah, yeah. I was about to say, I was wondering if it was an agonist, but yeah.
And that's really exciting because
Yeah.
they just wipe out all the symptoms of narcolepsy. So
Um,
the
are they
patient,
like being used right now or are they still being like tested? Okay.
yeah, no, they are in clinical trial.
Okay, okay.
It will
Interesting.
probably be approved, at the end of 2026. But the
Oh, wow.
results are very spectacular.
That's amazing. That's good to hear that it's coming like soon actually. I don't think it's
Oh,
in.
I mean, for me, it's like I'm like a kid in a playground.
Yeah. So actually, do you know how many when's like the first year you really started like kind of your journey with narcolepsy?
I don't know if you want to know. In 1987.
What? Oh
I
wow.
know.
That's a long time.
That's
Yeah.
a,
And I mean, is this now like the first time you're seeing like the potential for treatments? Like
yeah.
that's amazing. That must be amazing
So
for
I,
you.
I,
Yeah.
I found the cause in 2000.
Okay.
Uh,
Oh, okay.
that's
Wow.
25 years. It took 25 years from knowing that it was due to a lack of orexin to having the chemical like available as an agonist to treat these patients.
And I'm just wondering, do you work with any of the companies who are like kind of producing these drugs or
Of course, of
Oh, okay,
course. I mean,
wow. Yeah.
I'm a pharmacologist by training. That was my area.
Oh, okay. I didn't know that. That's so cool. Yeah.
So, so I help them to design the clinical trial, and I have patients right now that are in clinical trials.
Oh,
So
yeah.
they are taking the drug, and sometimes they're in placebo versus the drugs.
Okay.
Most of them right now are in what we call extension trials. So, we give them the drug or placebo for only 8 weeks, but
Yeah.
then after we give everyone the drug. So otherwise it'd be too cruel.
Right, right. That makes sense. Yeah.
And
And
then
being ethical.
and
Yeah.
then they take the drug for a while and for several years. And I have now probably 20 or 30 patients that are taking this drug for a year or more. And they're pretty happy.
Yeah, that's amazing. So, I also wanted to ask about like kind of the connection of narcolepsy with other systems, specifically like the role of the immune system. So, could you elaborate on like what you've maybe been able to learn about that kind of role as well?
Of course, you know what science is about. You always have one more question, right?
Yeah.
But
Yeah.
what is the next question? Why? Why these cells with orexin are missing, right?
Yeah. Yeah, that's true. Why? I guess.
Why are they destroyed? What's happening? Because you are born with your cells with orexin, and then suddenly something happened and you develop it. Sometime as early as 3 years of age, usually more like around adolescence or
Okay.
sometime, 10 years old. And then you have it for life, and the cells are destroyed. But what does destroy the cell? And now we know it's the immune system. And so you probably have heard that of autoimmune disease. So autoimmune disease are diseases where your immune system, instead of attacking a virus or bacteria, makes a mistake. It attacks your own self.
Yeah.
Many, many of them. There's like 5% are affected. Like rheumatoid arthritis,
Right.
is the joint.
Yeah.
Lupus is everywhere in the body,
Yeah.
including in the face. Multiple sclerosis is
Yeah. That's what I was kind of thinking about.
hundreds and hundreds of autoimmune disease.
Yeah.
So here, what's happening, and we have discovered the trigger. The trigger is the flu, which is very unusual because most of the autoimmune disease, they don't know how they start. But for us, we know that it's due to the flu. So people get certain type of flu and not others. Uh,
Um,
there's three different types of flus that circulate right now. There's H3N2, H1N1, and influenza B, Victoria. And it's only two out of three that when you get infected, for some people, we don't know why, when they have a certain genetic predisposition
uh,
and also probably bad luck, the immune response becomes abnormal. And instead of just only clearing the flu, it starts to attack your cells, thinking that they are infected by the flu.
I
And then
see.
it kills the orexin cells, and then you have narcolepsy.
So those like two types of flus kind of act as almost like a trigger for it.
Yes, the
Okay.
flu is exactly a
So
trigger.
if someone were to like live their life without contracting that flu necessarily, like would they be, I mean, get away with it?
Probably, but
Oh.
nobody gets away without the flu. So
Oh, okay.
everyone gets its first flu before the age of 7. I mean, 90, everyone gets at least one flu before age 7.
Right.
So your flu education, because your immune system learns how to respond in the flu. The
Yeah.
first time it encounters it, and the next time actually it will often reactivate the same immune response because it learns how to respond. And then after it's not new anymore, it just reactivates some cells that have been prepared to respond again. So your first flu is actually very important. It's called a primal infection.
Yeah.
And I actually, I believe that if we could figure out a way to give certain types of flu, like for example, the H3N2, which doesn't predispose to narcolepsy first, maybe people would become protected against narcolepsy because
Interesting. Like kind of almost like a vaccine in a way.
exactly. I
Okay.
think in the future we'll be able to vaccinate people who are at risk.
Okay.
Uh,
Oh yeah,
my,
I see
my
what you
dream, my dream now is to make narcolepsy disappear completely, you know.
mean.
So
Okay.
we will give like if I discovered you have the genetic risk for narcolepsy, which is always possible because there is, not everyone you know, then I could change a little bit the vaccine for the flu and
Yeah.
just change the part that is being confused by the immune system with the orexin, and then boom, you would never develop narcolepsy.
Wow.
You
So,
would,
is that like genetic predisposition? Like, can it be spontaneous too, as opposed to?
yeah, I mean,
Okay. Yeah.
25% of the
Okay.
population. 10 to 25% of the population is predisposed. So clearly, it's a big,
Really?
yeah, no, the genetic risk, I mean,
Wow, I didn't
it's
know
not
that.
very, no, but I mean, okay, it's
Yeah.
predisposed,
Okay,
but
I see. Yeah, I see.
very few develop narcolepsy.
Right, right. Yeah.
But you must have this kind of genetic makeup to develop it. So
Yeah.
let's say 90% of the patient of people are protected, but for 10% there is a risk.
Mm,
But the risk is still only like one for, 500, so it's not
right.
very high, you know.
Yeah.
So there's nothing to worry about it.
Is part of kind of like identifying these people at risk include maybe like genetic screening, or I guess what are you thinking about when you kind of th say
So
this idea? Yeah.
yeah, right now it's genetic screening, but what I'm hoping is at some point I will be able to analyze their immune cells and I will be able to tell, oh, they have dormant immune cells that are ready to react wrongly when they get the flu. But we have
Oh.
not identified these cells. That's my research now. I'm trying
You're
to,
trying to find those cells.
yeah, these cells that
Oh.
probably, maybe you have them, and then you are probably, if you encounter the flu at the wrong time, you would probably develop narcolepsy. But probably some people never don't have these cells and would never develop it. So it'd be really nice to know that.
Yeah.
And to maybe do some special vaccine for these people that will be very highly predisposed. So that's my research now. I
Yeah.
want to find a way to prevent narcolepsy. And
Yeah.
also, you should know that if you have narcolepsy, the risk of someone in your family to have narcolepsy is about 1%. So it's much higher, because of that genetic risk.
Yeah.
So let's say you have narcolepsy in your children, each of your child will have 1 to 2% chance of developing narcolepsy. It's not very high, but it's still kind of, it's getting high. If you have
Right.
10
Yeah.
children, it's 20%. I'm joking, but hopefully you won't have 10 children. But
Right.
I, I'm just trying to say that statistically, it's not negligible.
Yeah.
So for those people, finding a way to modify the vaccine, for example, would be very good.
Yeah. Yeah. Yeah, for sure.
And
So,
so that's what I'm working on. I think we'll find it.
yeah. 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 I hope so too. And kind of as like a follow-up on this question, one of the things I wanted to talk about is kind of technology and how it's maybe like able to help with analyzing data or like maybe the use of AI. So could you maybe talk about how like maybe AI and technology is helping you make progress with research in the past like few years and how you think in the future it's going to help with your research?
So I was lucky because for me, I had a friend who, when I was a postdoc, a student, he was doing vision research. So vision
Oh,
research is when they discovered CNNs and so forth, because that's where it all started, trying to recognize a cat from a dog with
yeah.
a network. So I've been kind of trained into CNNs and more complicated machine learning models from the
Wow.
beginning. So we use it for a couple of things. We use it for diagnosing narcolepsy, for example, with a wearable.
Oh, wow.
Yeah,
Okay.
we are trying to, everyone has a Fitbit or, this kind of, and we are trying to see if we can use the information to diagnose narcolepsy by using this foundation model, which are like sophisticated machine learning models.
Yeah.
So we are doing a lot of this kind of screening
Mm.
methods.
Yeah.
Let's say that we could maybe one day it would be possible to know who has narcolepsy based on their iWatch.
Yeah.
Uh, I think it's not going to be sufficient because the problem is there's always false positive. It
Okay.
needs to be so specific because narcolepsy is so rare. 1% for 2,000,
Right.
0.05%. So you cannot have one person that does boop, 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 and then that's a false positive.
Right. Yeah.
It's
Yeah.
difficult. But if we cross it with the genetic information or with something else, if they have the cells, then you might be able to do what's called multimodal machine learning, like you have the device, you have some genetic, you have something else, and you have different type of information. And then when you have all of that, boom, that can really give you a very high probability of narcolepsy.
Yeah.
So we are doing a lot of this kind of analysis, like trying to use device, and it's a very exciting area for
Yeah.
trying to understand sleep in general.
Yeah. Yeah. Do you think like the kind of technology to be able to diagnose like sleep disorders like beyond narcolepsy too, like it could be extended?
Oh, it's much easier to diagnose sleep disorder beyond narcolepsy
Right.
because
Yeah. Yeah.
narcolepsy is so rare.
Right. I
you
see.
will get false positive, even
Yeah.
it's impossible to be 100% specific. That's why you need other information like a
Mm.
questionnaire or genetics,
Yeah.
otherwise it's impossible. But for sleep apnea, for example, which is a very common sleep disorder,
Yeah. Right. Yeah.
that works. I'm sure you know people in your,
Right.
you know, that works very well with rings. There are some rings that measure oxygen.
Yeah.
Uh,
Oh, yeah. Yeah. Yeah.
the
We
problem is a
have.
lot of the ring, like Oura,
Yeah.
it's a bit misleading because they measure oxygen only every 15 seconds.
Oh, okay. I
It's
see.
not sufficient. If you really want to see your oxygen drops, you really want to measure it every minute, every second, or every 2 seconds.
More continuous in a way.
Yeah. And
Yeah.
some devices do that, and then you really get exactly the number of time you kind of stop breathing and have your oxygen drops. And
Yeah.
it's as good, pretty much as good as a sleep study.
Yeah.
And I think now there are also some devices that you can wear, and that record your brain waves.
Yeah.
And I'm sure you know of brain-computer interface,
Yeah. 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 Yeah.
So I think we have no idea what it could lead to. It's possible that at some point we'll have devices that would, I don't know, uh, open your door when you arrive close to your home or
Oh, yeah. Yeah.
about it. I'm just exaggerating,
Yeah.
but
Yeah. Yeah. I understand.
I'm just trying to say that there might be some very interesting
Yeah.
application, or we might be able to diagnose people who are going to develop Alzheimer. And
Yeah. Yeah. That's
so,
good.
so the idea is for people to wear this during the night, once every month or something, and then you see how it changes. And we already have shown that by machine learning, you can predict the risk of developing neurodegenerative disease or stroke. I mean, it's not a very big, perfect prediction, but we can kind of see an increased risk.
Yeah.
So I think with more work, we're going to be able to do this kind of predictive model, and it could really be like a way to, do your brain health.
Yeah. Yeah.
And
That's
then,
really cool.
yeah. So
Yeah.
it's a really exciting area for sure.
Yeah. Yeah. And I'm kind of excited to see where it goes. I'm sure you are too in the next couple of years. Like, I don't think either of us really know exactly like what's gonna happen, but I think it'll be really cool to kind of see it play out, you know?
I think we know where it's going to go in the next
Oh,
few years.
okay.
But
Yeah.
what's difficult to know is what's going to happen in 10 years. That's
Oh, yeah.
that
Yeah.
that's always, predicting what's happening in the next few years is easy, but 10
Right.
years,
I guess, yeah, the longer.
uh,
Right.
you know, that's really the real question that a lot of people are asking is would we reach like a super intelligence or not?
Yeah.
I have my doubts, but I just I've continued to be surprised. So
Yeah. Yeah.
I don't know.
Yeah.
Maybe we will. And then you will be obsolete. I will be old and you'll be obsolete.
Yeah. Yeah.
No, I'm joking. But
Yeah. A lot of jokes here.
no, it's
Yeah.
true. It's really exciting, but it's a
Yeah.
little bit I don't think a lot of the population really realize the progress that are being made.
Yeah. Yeah. Um, so my final question for you is one piece of advice you have for younger people, like students or kind of undergraduates, and kind of like if they're interested in research, like for example, me personally, like just one piece of advice you would have to kind of like explore or like work and try to contribute to scientific understanding.
I mean, it's difficult to do experiments, because now there's so many regulatory framework,
Yeah.
it takes like months to do anything. There's so much
Yeah.
paperwork, unfortunately.
Yeah.
This is really dramatic. I mean, we are bombarded by paperwork.
Wow.
So it's very difficult to do anything. So research is slow because of that. But otherwise, um, I think reading is probably the best, trying to understand, the different aspect. And then you can experiment on yourself. I mean,
Oh
I think
yeah.
nothing having, like measuring your own sleep and trying to see how to optimize it. I
Yeah.
think most people agree that what you need is to be regular
Yeah.
and neither sleep too much, because sometimes when you sleep too much, it becomes shallow, and then you put all your anxiety into it, and then you become even worse because you
Okay.
become worried about your sleep.
Yeah.
Or sleeping too little, then you become tired and sleep deprived, which also is bad.
Right. Yeah.
So my general advice is to sleep enough that you're not tired and not too much or not too little.
Yeah.
And the other issues that sometimes a bit difficult in people that are younger is the difficulty falling asleep. A lot of people have this kind of surge of energy in the evening
Yeah.
that prevents them from falling asleep. Interestingly, half of these people, it's social. So it's not like the circadian clock is abnormal. It's more like they like to stay around and like,
Yeah.
so they could sleep earlier if they really want it, but they just don't like it. So
Yeah.
about 50% of the people who were delayed, we call them social. I mean, it's more like and if they could, if they were to try, they would probably fall asleep
Yeah.
earlier. But then there are some people who are really delayed. So
Right.
the circadian time is really delayed and they can't fall asleep physically. If they were trying to go to bed at 10, they couldn't sleep, you know. And those, then we have to find ways to treat them, and that's a longer
Right.
story. But
Yeah.
one of the ways to try to expose yourself to light in the morning,
Yeah. Yeah.
try to be regular to shift your clock, but sometimes it's very, very difficult.
Yeah.
So that's a whole area. That's why we have doctors, you know.
Yeah. Yeah. And I guess kind of a follow-up question with that. So like when you mentioned like testing your sleep, how do you recommend like kind of being able to conduct interesting experiments on yourself?
No, I mean, I think a lot of this device, even Ura, is not like that bad.
Yeah.
Uh, I
Okay.
mean, it's not good for telling you if you have a sleep problem,
Right.
and it's not good to tell you, oh, you have 20% of your REM sleep, you know. It's just, it's roughly accurate continuously. So it's good for you to see how yourself compare from one night to the next.
Yeah.
So it's not so good to differentiate you and me, but to see yourself and how your sleep one night is versus the other, I think it's pretty good.
Yeah. Yeah.
Uh, but it depends what you want. I mean, if you really want to see if you have sleep apnea, for example, then you definitely need
Yeah.
something that measures the oxygen continuously during the night, which
Yeah.
very few devices do.
Yeah, we
Otherwise,
have a research center here that I kind of like go to every once in a while, like just to look around and talk to the director. But they have like home testing there, and that's kind of how they diagnose it.
yeah, but like you can buy on the internet, you can
Or
buy
yeah, yeah, yeah,
something called Circle, or there's several of them. I don't know. I don't want to make any like, but there's several of
yeah,
them that kind of measures the oxygen desaturation index, and
yeah.
those, they are pretty much as good as like screening for sleep apnea,
Oh
to be.
wow, yeah,
And you can do it at home. And so for people who are really heavy and snore and want to know how many times they drop the oxygen, that can be quite useful. And if they have like more than 30 for sure, they need to see
yeah,
a doctor.
yeah,
30 hours, you know, because
yeah,
that's really high risk for cardiovascular events and being tired, etc.
yeah,
I mean, most people say more than 15 per hour is a problem, but 30 is that for sure.
yeah, yeah,
But not you at your age, you won't have any problem.
yeah, yeah. I don't think so either. But yeah, yeah.
For your age, the problem is mostly like having problem falling asleep at night.
Yeah. And I guess part of it is social, like you mentioned, it's easy, like, especially like my phone's like always within my arm's reach. So it's easy to call people at night, when there's not as many like social obligations. You can kind of just scroll on your phone too. So it becomes like difficult, I guess.
Yeah, no, you're right. It's
Yeah.
social, and sometimes the social become biological because as you expose yourself to light in the evening,
Yeah.
then you shift your clock because your brain thinks that the sun is still up, so
Yeah.
it's kind of adjusting like later. So the
Yeah.
more you expose yourself to light, the more in the evening, the more you will delay your clock, and the more you expose light in the morning, the more you will advance your clock.
Yeah. 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 Well, on that note, thank you so much for
Uh,
joining me today.
it's
I
a
think
pleasure.
yeah, we had a great conversation. And it was really cool to hear about your research and kind of where the sleep research is headed these days. So,
It's great. Good luck. Bye bye,
yeah.
Sandy.
Yeah. Bye.